Good afternoon, everybody. Maybe good morning for a few of you, depending on where you are. My name is Haley Yates, the UBA Manager of Strategic Solutions. And on behalf of United Benefit Advisors and Allied, I welcome you to today's presentation in our UBA Employee Benefit Webinar Series. Today's topic is navigating high-cost healthcare strategies for effective cost management. And our presenters today are Dan McCarthy and Steve Savanna. And with that, Dan and Steve, the floor is yours.
Perfect. Thank you so much, Haley. Good afternoon. Good morning, everybody. So as Haley mentioned, we're going to be jumping in to a variety of different strategies for managing high cost activity within an employer health plan. We're going to spend some time kind of beginning just to start to talk about the place we're in the market in the industry, some of the trends that we're seeing from a large claim management standpoint. And then we're going to talk more specifically about some of the strategies of actually managing them. There are a lot of ways in which we can reduce spend within a group health plan. I think many of us on the call are familiar with those. The biggest challenge that we see is navigating that while not completely upending the member experience. Driving cost savings is great, but not at the expense of the member experience. And so that is really the foundation of our discussion today. Before we get into the nitty-gritty of what the strategies look like, I just want to quickly give folks kind of a high-level view of what we're seeing. What I'm going to present over the next few slides are some of the stats from one of the largest reinsurers in the country over the past several years and what they're seeing from a large claim standpoint. 20% of employers had at least one member with over $1 million in claims. That's just during a 4-year period. That was 2018 through 2021. It's only increased during that time. I give this example frequently. I've been at Allied for 13 years. Whenever I first started, we would see $1 million claims across our clients, maybe a few times a month. Today, it is sometimes multiple times a week. It is significant. In just over a decade, the increase in medical spend has increased dramatically. And so to ensure our employers' health plans remain sustainable, we have to really put these strategies really front and center. I don't want to discount things like proper primary care. We'll talk about that. Telemedicine usage, getting folks to properly use the urgent care over the emergency room, wellness initiatives. All those pieces are incredibly important, especially in the aggregate. But when we have such a small portion of a population driving such a large percentage of the healthcare spend, we really have to be thoughtful about what we do here. One of the largest claims, and this is actually a few years behind, $6.5 million was the highest claim that this carrier had seen during this time frame. That was for a NICU claim. Part of what we're going to talk about today are some of the strategies of impacting that and what we could do there that's not disruptive to the member. Looking at some of those top claim conditions through 2024, I think a lot of this is pretty familiar to most folks. Cancer is kind of leading the way, cardiovascular disease, orthopedic and musculoskeletal. Oftentimes, especially for the employers that are on this call, if you have that transparency in your data and you're able to see what types of diagnoses are driving the bulk of your claim cost, a lot of times this looks pretty consistent. NICU claims can obviously make their way up to the top 1 or 2 spots, depending on if you have that type of activity. It's common that we see cancer and cardiovascular disease and musculoskeletal claims really leading the way. And this is really panning out and looking over the past several years, looking specifically with this reinsurer and looking at what types of claims made it to the top of their list back to 2021. And again, not a lot that varies here. We do see that cancer, multiple myeloma, NICU and newborn claims really taking the top 1 and 2 spots throughout this period of time. So I mentioned this earlier, but this is again really the focal point of our discussion today. It used to be that we would say that in general across Allied's clients, but really across our industry, it was always about 4 to 5% of the population driving close to 50% of the spend. What we saw over the past few years is that that's actually trailed down. It's now about 2% of the population driving close to 50%. And a lot of that is just due to the result of having these enormously high dollar claims hitting employer health plans. So again, what we want to do is think about ways in which we can impact this percentage of the population, because this is going to be the most meaningful. If we don't focus our time here, this prevents us from having the fun discussions that we all want, which is to how do we improve our benefit plans so we can attract and retain talent. That's the whole idea about what we're doing. And if we don't have line of sight here, it's very difficult to achieve meaningful savings. And again, there are a variety of ways to impact claim costs. How do we do so in a way that's sustainable? So I won't spend too much time here. There's going to be really two areas that Dan and I are going to talk about today and really focus on. Allied Care is really the platform for our medical management platform. And again, I don't want this to be an Allied commercial. I really want folks to view this through the lens of these are ways and strategies that you should be talking to your vendor partners about. Some of these strategies are things that we believe we do best in class. But these really are carrier TPA agnostic. It should be things that at least you have line of sight on and are able to engage with your advisors and be able to be thoughtful about how we're navigating this. So Allied Care is that medical management platform, being able to catch some of these things up front during the prior authorization process. That's critical to directing care appropriately. Dan's going to spend some time talking about Allied Advocate. Think of that as really a behind the scenes strategy for mitigating certain types of large claim activities. It's really a way for us to negotiate and be a little bit more aggressive, especially when we see provider behavior from a billing standpoint that is difficult. I'm going to come back in and talk a little bit more about enhanced case management. Enhanced case management is a critical component of what we do. It should be front and center within any group health plan. Every group health plan today has large case management, and the idea behind it is to help folks that are in the midst of treatment navigate situations that are more challenging with a little bit more hand-holding from the vendor who's facilitating that. In reality, what we generally see is that it falls woefully short. And a lot of times the primary reason why it's being initiated is for carriers and risk takers, stop loss carriers, to be able to understand what the cost of treatment is going to look like. What's the progression of treatment for this member with a concerning diagnosis going to look like over the next 6 to 12 months? Because that's obviously critical as you're coming up for renewal to understand what that liability could potentially be. There is a lot that can be done outside of those two areas, helping members navigate really complex situations. I think it's the area in our industry that is really in the worst position. Health insurance is incredibly difficult for folks to navigate when you're in the midst of a complex condition and you have multiple providers, not really understanding how to navigate that, not just from an insurance standpoint, but just navigating your treatment. Having medical directors, nurses, clinicians, social workers, counselors, being able to really provide some hands-on support there, it's critical. It's becoming one of the best things we do as an administrator. And then lastly, behavioral health and wellness initiatives, obviously foundational to everything that we do. We want to encourage good health outcomes. We want to set really a culture of health within our clients, and those two components are critical for doing it. So we're going to spend some time talking about Allied Advocate. Dan's going to jump into that in a moment and how fundamentally how it functions and the ins and outs of how it works within a health plan. Before we do that, I'm going to have to go a little bit into the weeds here just to kind of define what payment methodologies, what reimbursement strategies exist within the market today. The commercial market, if we think of that as Blue Cross, Aetna, Cigna, United Healthcare, generally when you're buying a network, when you're buying any one of the commercial networks, you're buying two things. You're buying their access, how many doctors and hospitals and so forth they've contracted with, and you're buying their discounts, what they've contracted with those providers for certain services. And that's a big component of claim cost. That's not the only piece, but it is a very big component of what drives claim costs within a health plan. On average, the average discount you see with those commercial networks, probably somewhere between 50 and 55% on a good day. And again, that's translating directly into what an employer pays, fully insured or self-funded within a group health plan. If we were to look at some of the other strategies in the market for reimbursing providers, Medicare is one of them for those that are over age 65 and on federal Medicare. On average, those discounts are somewhere between 78 and 81%. There's some outliers that can be even significantly higher than that, that's meaningful. When we think about 50 to 80% spread, I mean, that is moving the needle in a significant way. And then many of you may be familiar with reference-based strategies, or RBP. Generally, that is using Medicare as the basis for reimbursement, but ultimately it's paying at a higher percentage. The idea being maybe that will increase acceptance rates within the provider community. When we do that, there are absolutely savings as a result, somewhere between 60-63% discounts on average. But I think most folks on the call that have some familiarity with these types of strategies, it can be very noisy, very challenging for plan members to navigate. Most of the time, these types of programs don't have a provider network, so you're not using an Aetna, Cigna, Blue Cross. You can go to any provider that you choose, but it's at the discretion of that provider as to whether or not they're going to accept that plan's payment as payment in full. And the practice of billing patients for that difference is very common within most reference-based models. And so I'm not saying that it's a bad strategy by any means. There are significant savings that can be generated through strategies like that, but oftentimes it is at the expense of the member experience. And so what we're going to spend some time talking about is a strategy that using some similar reimbursement methods, but very different in how the member experience functions.
Awesome. Thanks, Steve. So I'm going to jump in, and hello, everybody. I'm Dan McCarthy. It's nice to be here live in the UBA headquarters where both Steve and I sit today, beautiful Chicago, Illinois. I'm going to talk a little bit about Allied Advocate, which is an innovative cost strategy. One of the things Steve said when we first started this presentation is we wanted to find out strategies and ways where we could enhance the member experience without disrupting your care. So the things that Steve was talking along the lines of reference-based pricing programs, limited medical benefit plans, limited formularies within pharmacy benefit management programs, all ways that you can ultimately reduce care, but it comes to a cost of the membership. So it comes to a cost of the membership in terms of balance billed, denied care, or inability to receive services. At Allied, what we want to do is we want to control medical costs while enhancing enhancing member experience. So we do that through a number of programs. Steve will talk about enhanced case management later, but right now we're going to talk about Allied Advocate. Allied Advocate is a strategy where we can limit certain claims within a PPO environment to Medicare allowable while providing members additional support in terms of an advocacy program. So the members are assigned a team that works directly with the member to make sure that they're not put in a balance build situation. So oftentimes, Steve used the statistic earlier, 2% is driving 47% of the cost. If you have 100 employees on a plan, you have a handful that are driving 50% of that cost. So anywhere from 2 to 4 to 5 people. What we do with this strategy is we provide them a team in which we will negotiate their claims at Medicare allowable. And we're going to look at particular categories within a health plan, and depending upon network PPO that they're dealing with, we're going to be able to apply those strategies. And the strategies are dialysis, ambulance, infusion, outpatient surgery, catastrophic claims, and physician claims. And when you look at what we accomplished in 2024, we had $413 million come through these strategies, these programs. $260 million would have been paid if we were simply to apply the PPO discount. What we actually paid was what we actually paid is $96 million. So we had a savings of over $160 million that went through that program. Now, if we were a traditional carrier, an ASO carrier through a network, our value is really driven through, as Steve mentioned, provider access and then also discounts. We take it to the next level where we're looking at that small percentage of claims that's driving that 50% of the cost. And then we're saying, where can we find additional savings? These categories enable us to produce that while enhancing the member experience. And again, this is what we see as, Steve mentioned, typical network discounts, anywhere from 45 to at the highest 60%, where we're achieving 76.7% on those high dollar claims. So again, 2024, over $160 million savings. Super proud of that statistic, and it translates into lowering costs, not only from a claims standpoint, but also when our self-funded clients come up on their reinsurance renewals, they're seeing reduced lasers and lower premiums as opposed to that if we would have paid at the traditional PPO allowable. So again, it's providing an enhanced member experience while ultimately lowering costs and producing better renewals and outcomes on behalf of our employers. What generally happens within these strategies and where we're seeing an enormous amount of success is 63% of our provider community, which is generally facilities, is accepting at that flat Medicare allowable. We try to negotiate. Where we're seeing is about 2.8% negotiation where we get a lower than PPO discounted rate. And in worst case scenario, we're going to have that PPO backstop where we're going to be at 34%. So even if we try and don't succeed, we're still providing the member with a better experience, and we still have that PPO as a backstop, as opposed to a reference-based pricing program where you could be stuck in the jam with balanced billing and back and forth between the provider and the carrier. This is a very integrated, customer-friendly model.
Yeah, I would just add, this is what really differentiates this from most of those reference-based type programs where, to Dan's point, you're negotiating to an arbitrary percentage of Medicare members and collections, they're getting bills, and it's just a lot of back and forth. This functions very differently. We're going to be as aggressive as we can out of the gate. And again, on a small percentage of claims. This is not impacting the $500 outpatient claim. The idea is that we're targeting the large claim activity only. We're doing the best we can out of the gate. If we're getting some pushback, we'll negotiate. But if we fail, we'll fall back on the PPO allowable. The worst case scenario, if we failed 100% of the time, which we won't, but we're going to pay the claim the same way we would have had this never been in place. That's what makes this sustainable. We need to be aggressive, but we also need to ensure that the member is not stuck in the middle of that process. To Dan's earlier comments, this is where we will see from a stop loss standpoint, for those of you that are self-insured today, especially if we have large claim activity that's ongoing. Somebody may be in the midst of dialysis treatment or in an ongoing infusion. When we have this language in place, just by virtue of these success rates with many of our carriers, we do see reductions in stop loss premiums and aggregates just for having this sitting alongside. Depending on the network we're using will dictate how much flexibility we have. We do have language that exists within Aetna and Cigna and Blue Cross that does have components of this. But we do have access to really broaden the scope of the types of claims we're targeting if we're using some of the other national and regional networks across the country.
Dan and Steve, we did have two questions come in. The first question from John, do the network contracts prohibit RVP pricing on specific claims?
They do. So that really kind of dovetails nicely. So if we're using a commercial network, the Aetnas and Cignas of the world, and you can understand the sensitivity behind it, we're basically stating we want plan limitations in these areas to be able to pay more aggressively. Networks are very sensitive to that since they have these provider contracts. They only allow us to do it in those key areas, right? Using an example, one of our commercial partners allows us to do this work for dialysis claims and infusion claims only. Some of the others may just allow the dialysis prong. Whereas if we're using some of the more regional networks, First Health is an example, they'll allow the full scope of the program. So we're able to target any type of large claim activity. But that is something that we generally review on a case-by-case basis. Most every client is seeing some infusion activity at this point. And so it's meaningful. We're not going to be successful 100% of the time, but if we're able to really get acceptance on a handful of those claims, the savings can be significant. And if we fail, we're paying that claim at the PPO allowable rate and moving on to the next one. So very, very different. Oftentimes when we see these really aggressive strategies in the market, they do drive significant savings, and some of which Allied offers. Allied is probably the largest reference-based administrator in the country. And for the right client who's in a position where they may not be able to sustain their health plan anymore, they can't take the 30% fully insured increases and they're faced with dropping coverage altogether. Those far more aggressive arrangements, they can be appropriate. If we're not in that position, I really prefer looking at this as more of a hybrid approach. Let's have a commercial network. Let's target the large claim activity that we can within it. And we'll spend some time talking about other strategies that we utilize alongside of this. But within our network contracts, these are the areas we're really focused on.
Second question, and I might not be reading this correctly, but for this slide specifically, is the 63% a discount off of a provider's non-transparent, the provider's charge master's price list?
So the
This-
63, oh, sorry, Steve, you want to go ahead? Or you want me to?
No, go ahead.
Okay, so the 63% pertains to the percentage of providers who are accepting our flat Medicare rate. So it has nothing to do with the charge master, it has nothing to do with any artificial charges. So it's just simply saying, hey, of the providers that we presented this flat Medicare, not Medicare plus anything, we're seeing a 63% acceptance rate of that Medicare rate, which then transcends to that, call it 76 to 80% discount.
Yeah, I'm just going back really briefly here just to illustrate. I think this kind of goes at the heart of the question of comparing the actual reimbursement amount versus a PPO allowable. That's what this slide is really illustrating, not the acceptance rates. Although it does kind of all play into this. The stats on the far right side of this column, the percentage of savings from the charges, you almost want to view that through the lens of how does that stack up against an Aetna, Cigna, Blue Cross, right? Maybe a United Healthcare, maybe 50, 55% discounts is what we're generally seeing from each of those commercial networks. With this strategy, all in, about 97% discount off of dialysis claims. It's the most successful component of this program. Infusion therapy is about 67% and so on. So different, this is where it actually translates to what are the actual claim savings. And really what you do is compare this against what a traditional network contract is yielding.
One more question, again from John. Do the quotes state there is a hybrid RBP/network offering?
If we're quoting this, and it's purely optional, but if we're quoting it, that is something that we want to talk about through that quoting process, because depending on who is handling the reinsurance marketing, it is very helpful to let the carriers know that, hey, we're assuming, whichever network with the allied advocate strategy. If the underwriters know that and they're an approved carrier, which virtually most of the A-rated carriers in the market are approved for this strategy, that's when we do start to see underwriting credits as a result. Especially, if you have a contract that allows lasering, we generally see significant reductions in lasering, especially in the areas of dialysis and infusion. If it's a no laser contract, then reductions in premium and fixed cost.
Thank you.
So this is just an example of dialysis. When we get in dialysis claims, it's really a no-brainer because you always have Medicare as a backstop due to Medicare secondary payer rules. So as a rule of thumb, we're at about 4% reimbursement rate on dialysis claims. So in this particular outcome, it was $1 million in savings. And there have been case again where we go in and we do analysis based on existing self-funded clients' claims experience, where we can say, we know that we're going to save you at minimum $250 million on every dialysis claim that we come across, which, as Steve mentioned, then leads to a lower or removed laser.
Dan, I can't hear you super well. I don't know.
Sorry. Okay,
There
I'll
you
get
go.
closer.
There it is.
Gotta go a few inches forward.
Yeah.
So this is the next piece we wanted to discuss. I kind of introduced this a few moments ago, but this is separate from Allied Advocate. So again, Allied Advocate's a strategy within the network contract. There's a handful of areas of large claim activity that we're targeting. Enhanced case management is really network agnostic. We can utilize this program within any of our clients regardless of the network. And again, it's really designed to go several steps further than traditional case management does. I won't go through each of these areas, but I will just highlight a few of them. Site of administration. That relates into infusion therapy. And that is really targeting some of this provider behavior. I'm sure many of you on the call have seen this, but we see a lot of facilities that are buying and billing for high dollar infused medications. They're buying these medications. They're sometimes marking them up 2, 3, 4 times or more what the average wholesale price of that drug should be. If that treatment meets medical necessity and it's within their network contracts, we have to pay it. As the administrator, we're contractually obligated to do so. And so this is allowing us some flexibility through the plan language to move those infusions out of a facility setting, generally into a home infusion setting, or to a standalone infusion clinic if the member is more comfortable in a medical setting. What I typically tell folks is the language is very rigid. The execution is far more flexible. We typically allow the first 1 to 2 infusions to be done in a hospital setting, which if I'm starting treatment that requires an infusion, that's exactly where I want to be. But if the member is stable, has responded appropriately, and we're seeing that type of provider billing behavior, that's the time whenever we want to step in. We generally start by engaging first with the member, letting them know that they don't have to have that medication infused in the hospital. We can facilitate having a nurse practitioner infuse that medication in their home, or finding a close by infusion clinic. And again, we won't be successful 100% of the time, because again, we're always measuring these types of strategies against member experience. We have to be very thoughtful and sensitive to that. If we're successful a handful of times, I mean, this could be hundreds of thousands of savings on one member. They don't have to change their drug. They don't have to change their provider. Other areas where this comes into play could be coverage evaluation. So that can take a variety of different forms, but one of the things that we often see is that, you have somebody who's in the midst of treatment. They may be unable to be actively at work. They go out on FMLA, they exhaust FMLA. Generally, depending on the employer's leave policy, they're offered COBRA at that point for a dramatically higher rate than their contribution. And so our team will oftentimes engage with the member. We're not there to force them to do anything. That's not the intent. It's there to have a resource help them navigate their options. That could be staying on the group health plan and electing COBRA. That could be looking at an alternative plan outside of the employer health plan. It's having a resource that has full access to their claims experience, knows the providers who they're using, understands their formulary within their prescription drug benefit, and being able to help evaluate what plan options exist outside of this. COBRA premiums are much higher. What I will add, candidly, Allied is a COBRA administrator as well. It's weekly. We see hospital systems doing the exact same thing. Hospital systems are notorious for understanding when members are out on FMLA and offered COBRA. If they believe that there is going to be a risk that that member can't afford their COBRA premiums, it's not uncommon for them to write the check and submit the COBRA paperwork on behalf of the member and get them reinstated in the health plan. Perfectly legal for them to do that. Kind of falls into a gray area, but there are some hospital systems that don't even hide this. We get their COBRA premium payments on behalf of our members on their check stubs, and we have no choice but to reinstate them. And in effect, what that hospital has done has shifted the risk back to the employer health plan, because they know that if that member can't afford COBRA and they're on a Cigna plan or a Blue Cross or Aetna, and they're losing coverage, they may go on to state Medicaid. And if I'm a hospital system, that means my reimbursement has been cut significantly. So it's far more advantageous for me to write the check and shift the risk back to the health plan. And they do that through the guise of, we're helping our patients in a difficult time. The last thing we want to do is burden them with a change in their coverage. Okay, if that were true, they'd be doing it for everybody, and they're not. They're doing it specifically for those that are in the midst of high dollar treatment when they believe that member's financial situation is going to lead to them not electing COBRA. So I say that because if we're not at least talking about these types of strategies, and it's not going to always be appropriate, we're just going to continue to see claim costs continue to rise. And so we have to have some line of sight in these areas and at least be willing to discuss them. What that team is doing. So there's a variety of ways that we identify members through this, and this is all work that we've done in-house. When I started at Allied, this team, again, separate from traditional case management, this team on the enhanced case management side was about 5 internal people. We had a medical director, clinicians, counselor, social worker. The team is now approaching over 90, and they are tasked with looking at these areas that are of concern. And so they're evaluating pre-certs and prior authorizations. The first time a concerning claim may hit our inventory. Internal and external referrals, also ways in which this team gets engaged. There may be a situation where a member goes out unexpectedly on FMLA, and the HR department knows this and knows the member needs some extra help navigating what they're going through. That's an appropriate time to engage our team. Members can also self-refer through our app, through our portal. So if they believe they have a situation that requires some additional help, members can engage directly with our team through the portal. And again, this is really designed for folks that are going through something that's more challenging. A lot of requests that we are seeing lately is on the mental health side, just everyone knows there's just a huge shortage in this country with mental health access. Finding providers that are in network is challenging, that are accepting new patients. Oftentimes the wait times can be 6+ months. So this team does have resources, virtual resources that we'll talk about, that are able to help connect folks to licensed providers or clinicians, counselors when it's appropriate. That data goes to our panel. We have an ECM panel that reviews each situation. They develop a initial strategy for how they're going to engage with that member. And then on an ongoing basis, that member has direct communication within that team. This is not something where they're just working with them up front and trying to shift cost. This is an ongoing process. The whole idea behind this is that the member is first. The plan is secondary to that. If we find a situation that's going to put the member in a worse spot, but drive significant claim savings, the process stops. That's not the intent. We're looking for a scenario that's going to put the member in a better spot first and foremost, and the plan benefits secondary to that. The other pieces we're going to spend a few minutes in the short time we have left. I do want to talk about primary care and navigation. MSK, musculoskeletal programs, is a component of that. But we spent the last several minutes talking about large claim management, which again is critical. One of the stats that was incredibly interesting to me was that of that 2% that we talked about earlier, driving close to 50% of the claim cost, our enhanced case management team looked at some of the stats for those outreaches that we've made. It was over 40% of those that they reached out to that did not have a primary care physician. And sometimes the first time that they were really getting engagement on that front was after the heart attack that put them in the hospital for weeks. So very critical piece that we'll spend some time talking about. Really briefly, this is just another case study, another impact story illustrating that site of care language that we talked about, just moving a patient out of a hospital setting. This is an example of a 50-year-old who was getting a high dollar infusion for ulcerative colitis. Every 8 weeks going to the hospital for that. We found that the provider was billing more than double what that average wholesale price was. And just by virtue of moving that member's infusion to their home, it drove about $60,000 in savings each year. Didn't have to change their drug, didn't have to change their provider, just where they were getting that infusion. Okay, I know we've been talking fast, but I want to cover these last few remaining pieces because I think these are also critical. So we're going to spend a little bit of time talking about virtual primary care and navigation. Those are two key areas we've really spent the last few years really diving into and making certain we have appropriate strategies in each of these areas. We partnered with Recuro Health after a long process of evaluating a variety of different vendors within the space. As our preferred virtual primary care provider, fully integrated into our portal. And again, the idea is that we're not trying to somehow push a member away from their primary care provider that they may have today. This is really targeted with folks that either don't have a primary care provider today or have very low engagement with their current provider. So we'll spend some time talking about that. And then lastly, navigation. If I'm going through something that's complex, or maybe I have an orthopedic surgery that's coming up and I don't really know where to turn. Cost is not the only concern with these situations. We also want to make sure we're providing the best possible care. If the intent is not to drive folks to the lowest cost provider, it's to drive folks to the providers that are reasonably priced, but have the best outcomes. That's the most critical piece. We don't save a plan any money. We don't help the member if we send them to a provider who's very low priced, but ultimately you have numerous recurring visits because the surgery was unsuccessful. So won't spend a ton of time here. There's a lot of words on this page, but really this is just discussing what we already reviewed. Primary care today has been an enormous challenge across the country. I think a lot of that was present pre-COVID, no question, but it hasn't helped, right? And this is different than what you would see with standard telemedicine. Telemedicine is great, but that's more like a virtual urgent care. This is really trying to address the many claimants today that just don't go in for those routine preventive screenings. They don't have a direct relationship with a licensed medical provider. It's really trying to make this as easy as possible for folks to get into a provider and develop that relationship. It's just a quick comparison of what that looks like if we were to compare what virtual primary care looks like versus telemedicine or a virtual urgent care. When you have a virtual primary care physician, you have the same provider, right? This is your physician, just like we do today. If you're seeing somebody in person, this is all done virtually, but they're still able to request lab work, imaging, be able to have continuous follow-ups, be able to have a platform in which you can communicate back and forth within the provider. The idea behind this is that engagement is really the biggest problem we're seeing right now. And if we can remove some of those barriers, it's going to improve the experience for everybody. And this just gives a sense for why we selected Recuro Health. So they have over 2,000 licensed providers across the country. They're able to obviously fill prescriptions. All of that is housed within the member portal. It's a dedicated provider. And then they have a variety of other programs that are embedded within this. So obviously behavioral health is a key component, lab reviews and so forth. As we looked across the scope of the market, because there's a lot of folks within this space, Recuro seemed to check all of the boxes that we were looking for and provide that level of integration within our portal that we were looking for. This just gives an idea of some of those services that they can provide through that, through their system, through their service, but capturing family history, your behavioral health, lifestyle factors, at-home screening for certain types of labs, genomics, having that dedicated provider for 24/7 care. These are all critical pieces that make up that experience. And then also being able to help work with our team on that referral component. Dan's going to spend some time talking about navigation. We had to have a very clear line of sight with this. And this is one of the challenges when we have a bolt-on program. Some of our clients have engaged with outside virtual primary care vendors in the past. Having that full integration where it's not just primary care sitting alongside of a health plan, it's really integrated within it, gives our clinical team full access. We know exactly what that member is being treated for. We know that full clinical picture. That's incredibly helpful as we talk about navigation. And Dan, I will turn it back over to you.
Awesome. So the key piece being is, as we wrap, we're about 5-6 minutes away from being done. Number one, how are we going to control high dollar claims? And we illustrated that through Allied Advocate and enhanced case management. But two, how are we going to enhance the member experience? So as Steve mentioned, virtual primary care was a necessity because what we saw from a utilization standpoint is an historically low amount of participation in terms of having a primary care physician. So the next iteration is not only do we provide virtual primary care, but when someone does have an issue or they need to see a specialist, how do we get them to the right provider with the best service? And it's not all about cost, it's about outcome. So what we do with our enhanced case management team is we're working with the member to get the provider, the right provider. So for example, if I need an MRI and I have an issue with my meniscus and I live in South Carolina, that enhanced case management member is going to work with me and we're going to utilize the data to direct me to the most appropriate position in the event that I need a further procedure. So on behalf of the member, it's a better member experience. On behalf of the plan, we're achieving better outcomes. The back room and the data accuracy that we use is Garner Health. That allows our team of enhanced case management folks the ability to pull from established data, and it's not coming from us, it's coming from the system as a whole, where we can say, here is the provider that we can send you to for the best outcome. So we are 5 minutes left, and probably Haley, do we want to open it up for questions?
Yeah, I know it takes an extra 20 seconds to physically type a question, so we'll leave that Q&A open for now. I did see some comments about not being able to hear. I do want to remind everybody this is being recorded, so it will be shared to watch afterwards if need be. But I haven't seen any additional questions come through. But I will thank everybody and Dan and Steve specifically for your thought leadership and sharing your expertise today. And of course, everybody else that joined us today, our UBA partner from employees and any clients and any others who are here. Our next webinar is on the 15th. We'll be discussing if you are ready to make the move from fully insured to self-funding. So with that, I want to thank everybody again for attending our employee benefit webinar series, and we look forward to you joining us next month.
Thanks, everybody.
Thank you.